So I want to invite Ivo Bernat to give his presentation on slender radial artery occlusion. Please, Ivo.
So thank you very much. In this moment, we have a strong recommendation for radial approach for a routine use, and after proper training, also for treatment STEMI patient by primary PCI. But we must know that the radial artery is the same artery as coronary artery in terms of diameter, and sometimes it's smaller. You can see on this slide that sometimes radial artery is really small. Sometimes in case of high takeoff, procedure can be performed with some complications, and sometimes severe calcifications and absence of radial artery can limit the procedure, and we can do it from ulnar, but only with the partial insertion of the forefront sheath. In Japan, about 40%, from 20 to 40% patients have femoral radial artery smaller than 6 French. But also in France, some patients have small radial artery. So if the recommendation is perform a majority of procedures through radial, we have to know that there is a dark side of this approach, and it's at first radial artery injury, which occurs almost always, and also the risk of radial artery occlusion. Incidence of radial artery occlusion is reported in wide range, and risk factors are prolonged high pressure compression, repeat procedures, and low radial artery to sheath ratio. Prevention and treatment is adequate anticoagulation and patent hemostasis. Majority of procedures through radial approach leads to radial artery injury. It was confirmed by IVUS ultrasound study, and a few years ago also by OCT. Injury of the artery is acute on different degrees and chronic as a neointimal proliferation. It means if we perform radial artery procedure and radial artery is so small, we have some problems, and repeating procedures are complicated due to friction and spasm. If we use smaller size of the sheath, the rate of radial artery occlusion is lower. And if we use heparin, the radial artery occlusion incidence is also lower. This information we have for many years. What is new is the fact that sometimes we compress radial artery too long, and in this case we can have a higher incidence of radial artery occlusion, which was confirmed by Pancholi. There is a table, reported incidence of radial artery occlusion, thrombosis, and you can see how many different values were found. What is basic is the use of patent or perfused hemostasis in comparison to standard hemostasis. The difference is absolutely significant. How to reach perfused hemostasis? It's very simple. After sheath insertion and releasing the pressure, during compression of the ulnar artery, we can see if the patency of the radial artery exists or not. If not, as soon as possible, we need to repeat deflation in TR band in this example. And when we reach perfused hemostasis and the duration of the compression is short, the risk of radial artery occlusion is minimal. You can see it on this slide. This is a summary of studies from last 4 years. And when you use perfused hemostasis, adequate anticoagulation, the risk of radial artery occlusion can reach 1%. In our study, it was due to the immediate ulnar compression after the diagnosis of soon radial artery occlusion. The idea is from China. Many years ago, they presented in their congress the fact that when you compress the second artery, you increase the pressure to the second one, and we can use it very easily by the same TR band compression. In our study, it was 1 hour ulnar compression, and successful recanalization was reached in 70% of patients with 5,000 units of heparin and 30% patients with 2,000 units of heparin. So we have some factors which can increase the risk of radial artery occlusion. So diabetes, female gender, low body mass index, low coagulation, bigger sheets, repeating cannulations, and occlusive hemostasis. There is managing strategies and treatment, smaller sheets, adequate anticoagulation, and patent hemostasis. Some radial artery occlusions spontaneously recanalize in time. We can use ulnar artery compression. We can use 4 weeks low molecular weight heparin, and in rare cases also intervention. And what to do next? The question is slender as a solution. The answer by me is yes. We saw that Japanese colleagues showed us many tricks which were also published. And in Europe, we have no so many tricks at present, but we can do something, I think. Professor Saito presented in late-breaking clinical trials in AIM Radial in New York last year results of the comparison of 4 French guiding versus 6 French guiding study, and this study demonstrated that there were reduced hemostasis time and exercise-related complication, and there was minimal risk of radial artery occlusion in comparison to 6 French, and it means that reduction of the sheath or equipment leads to reduction of incidence of RAL. Another possibility at this moment in Europe is a new integrated delivery system from Svelte. And in my institution, we have some experience with 4 French diagnostic catheters, which can be used for simple PCI. For example, in this case, high takeoff of small radial artery, old man after bypass, with occlusion of the right, which is chronic, and tight stenosis of vein graft, which was catheterized by 4 French diagnostic Amplatz catheter. We decided to treat it by this system through 4 French diagnostic catheter, and the procedure took a few minutes. It's an integrated delivery system, and crucial in this case is the position of the tip of the catheter, which must be on the same line as a ostium of the treated vessel. Is another example. Old man with poor left ventricle function, calcified, but not too much. 2 lesions. This is one which is tight, and it was 4 French diagnostic catheter, and for a better support, we changed it to Judkins left 5, and we treat it also very easily. After deep intubation of diagnostic catheter, first stent was implanted, and then after nitro, we saw that the second lesion was also significant, and that's why we implant the second stent. Finally, 4 French diagnostic catheter, which was deeply intubated, was stabilized in the ostium, and this is the final result. This new type of the sheet was also mentioned, so it's not necessary to repeat it. Another thing, how we can prevent or reduce acute injury of the radial artery, is this trick with balloon assisted tracking, which can reduce everything which can be dangerous for radial artery. So in conclusion, let me say something like message from all radial arteries. Use slender techniques to minimize radial artery during PCI. Use compression techniques with patent and short time hemostasis. And slender techniques and slender hemostasis are not only an option, but something what is necessary for next radial procedures. Thank you.
Thank you, Ivo. We are running 5 minutes over the program, but I think we still have time for a couple of questions to you. You can stay there, come here. So are there questions from the audience or from the panel?
We need a randomized trial, and this is exactly what we'll do.
Yes. Screaming loud. I don't see microphones. So.
Sorry, short question. What hemostasis time would you recommend for use of 6 French sheets?
Our protocol in my institution is inflation. We use TR band, and we use 15 milliliters initially on the table. When patient goes from the cath lab, after a few minutes, we reduce the inflation to maximum before the discharge from the cath lab. On the standard ward or on coronary care unit or on same-day discharge recovery room, first nurse deflate next time to minimum. So I think the trick is that the hole to the radial artery is smaller and smaller. And thanks to this, our compression time is 30 minutes in 4th range, about 50 minutes in 5th range, and from 50 to 70 minutes in 6th range. But sometimes we have cases with 6th range, 35 minutes, 40 minutes. And the rate of radial artery occlusion is really...
For diagnosis on PCI or for both?
For both, of course.
And yeah, one more question. Yep.
Is there any data supporting the reopening of the radial artery?
Reopening of the artery. There are some articles which describe this technique, and it's like case reports. The biggest group of such patients, I think, has Babunashvili in Russia, or I know also that Samer Pancholi and some colleagues in US recanalize it. I think Sasko is also expert in this. So I think it's a report of series of cases, but I don't know more. Sasko, do you know?
We usually recanalize a fresh intima first month. We do not recommend to clinical pediatrics. But technically it's doable. Radio we presented around 30 cases between a few weeks up to a year old, but you have to make a balance between the risk of and the benefit of the procedure.
Okay, the last question, and then yes, please, and then we move to the next.
Tell us more about the umbilical compression. What did you use? When did you decide that the radar
We learned this technique from AngioSoftNet of Professor Hammond. There was a presentation from China with clear description how to do it. The trick in China was that they compress it manually for many hours, and it was impossible in our institution. So we decided to try the safety and feasibility of 1 hour ulnar compression immediately after the diagnosis of radial artery occlusion, which was performed in our study 2 or 3 hours after hemostasis. So patients with radial artery occlusion were incorporated to this technique, and in the group of 2,000 units of heparin, recanalization was successful in 30%, and in the group with 5,000 units of heparin in 71% of patients. So now when we know that radial artery is occluded few hours, or now we use it in lower number because we know it immediately, and the rate after our nurse experience, the rate of radial artery occlusion in case of very short intervals of deflation of the TR band is really minimal.